Thank you.
Okay, good morning, good afternoon, good evening, wherever you are. Welcome to our global CME webinar. This is the last for the year before we can actually break off and enjoy the lovely sort of winter festive season. I would like to kind of actually welcome you all on behalf of my co-chair, Dr. Naseem Naqvi, consultant stroke physician, who actually is with us today. And it's my pleasure to invite one of my colleagues who I worked before in the past, the recent past, I should say, was actually now moved to Nottingham, Dr. Sunita Dekchandani, consultant acute physician, a well-known name in the world of acute medicine, who's actually got a special interest in echocardiography. She's also kind of actually a PACES examiner and has got many hats and many roles across her sort of actually specialties. Sunita, welcome you on board, and I'm really looking forward to kind of actually talk, and I'm sure that we'll all learn a lot from your session today. And I'm also co-presenting with Sunita towards the very end of the session. This is because one of our speakers actually could not make it today, so I had to actually do a presentation, but I'm hoping that you will enjoy both Sunita's presentation and some of the learning lessons my presentation has. So without any further ado, I will invite Sunita to kind of start her talk. Thank you very much.
Thank you, Mansoor, and thank you, Naseem, of course, for the very nice introduction as well there, Mansoor. Thank you very much. I hope everyone can hear me all right. Do I have to wait if anybody wants to put it on the chat box if you can't hear us? Okay.
Yes, we can hear you. Yeah.
Wonderful. So Mansoor is going to control the slides, if that's all right. We'll go through the slides. So today I have a case of heart failure patient, which we come across, be it as general medicine consultants or acute medicine consultants, more or less every day, and how to manage these patients, along with incorporating the European Society of Cardiology guidelines on heart failure, is the main theme of today's discussion. I hope that's okay with everyone. So slide 2, Mansoor, please. So we have a 87-year-old male who's presented with breathlessness, leg swelling, whose background is hypertension on benroflumetazide. There's loads more to say there, but these are the brief main points which we want to see. And clinical examination, he has bilateral pitting edema, including sacral edema, and his JBP is raised by basal Krebs, with heart sounds which are irregular but no obvious murmurs. And ECG was atrial fibrillation with blood Susanese, fulvic counts, LFTs, more or less unremarkable there. Next slide, please. So this is his chest X-ray, which I'm more or less confident all of the audience would be able to say this is more or less bond or pulmonary edema with bibasal to more or less a big right-sided effusion with bibasal haziness, with fluid in the fissure, with upper lobe venous marking and pulmonary congestion all over the lung fields. So yeah, clinically this is heart failure. So next slide, please, Mansoor. Next slide. Okay, yeah. So we're happy to say this is heart failure. Now, ESC, if you press enter again, Mansoor, please. ESC has endorsed the definition of heart failure. More or less, it's a clinical syndrome consisting of the symptoms, which our patient presented with accompanied with the signs which we picked on, and it is due to the structural and functional abnormality of the heart that results in elevated intracardiac pressures or inadequate cardiac output at rest or during exercise. And enter, please. So what next tests tests would you consider in this patient? I know with a virtual audience, it's a bit difficult to get an audience answer on this, but majority of us would definitely want an ECG, which I've already mentioned, but yeah, it's very rare to find a normal ECG in a heart failure patient. So first thing on my water hand, I would always ask for is an ECG on these patients. So we know this patient had AF on their ECG. And if we go on to the next slide, please. And if we press, yeah, that's the one. So this is more or less the diagnostic algorithm produced by European Society of Cardiology. This is a new presentation for heart failure where you've gone through the symptom signs, and there's a particular importance to the NT-proBNP and echocardiography. So, sorry, I think you've gone one slide ahead, Mansur, if you go back. Yeah, this is the one for the new heart failure.
So, and then the next slide.
Oh, I think it's not coming up with the flow chart. That's fine. Okay, so more or less, the ESC mentions about doing ECG, and the echocardiogram, and doing the NT-proBNP. Now, NT-proBNP in acute heart failure of more than 300, it depends where you're working. In majority of UK, 300 to 400 and above NT-proBNP is an indicator of heart failure. And especially with abnormal echo as well, is more or less a high predictive value of heart failure for these patients. Now, this is the diagnostic algorithm for patients who already have been diagnosed with heart failure, and then you further classify them into the 3 groups of heart failure, which is based on the ejection fraction. So if we go one slide forward, Mansur, which would be, so if you notice, this slide will tell you NT-proBNP of more than 125. These are the chronic heart failure patients. So this is the classic. Yeah, sorry. This is the classification of the more or less heart failure based on ejection fraction, which I'm sure you all have come across now. Heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, which used to be called mid-range ejection fraction previously, and heart failure with preserved ejection fraction. As you can see, both of them have more or less 1 and 2, which are symptoms and signs present, with nextly based on their ejection fraction classified. Okay, so reduced ejection fraction have less than 40%. A normal ejection fraction we quote is more than 55%. So 41 to 50% is mildly reduced ejection, and patients with HFpEF, which is heart failure with preserved ejection fraction, are the ones difficult to diagnose, where you would say symptoms and signs of heart failure with LV ejection fraction more or less appearing normal, because normal is above 55%, but even more than 50%, it's quite subjective to say that. And then other features which you need in this group of patients are objective evidence of cardiac structural or functional abnormality. So you might have features of LV diastolic function, like big atria, reduced diastolic excursions, including raised natriuretic peptides, which we spoke about earlier. So that's how we would further classify our patients' heart failure diagnosis. But again, that's still not a full diagnosis of for the patient, because we've only more or less given them pathological diagnosis based on their ejection fraction. We haven't given an etiological diagnosis here. Next slide, please. So this is a slide which Dr. Ali will play for us there. Now, I'm not sure if you've ever done echocardiogram before this or seen an echocardiogram before this or done echocardiography. So Dr. Ali will point out the right ventricle, which is the top there. And this is a parasternal long axis where we are slicing through your heart as it is sitting. And then you have the left atrium, if you point out, Mansur, further down, yeah, left atrium, which drains into left ventricle through the mitral valve, and left ventricle drains into the aorta through the aortic valve. So you've more or less found out the walls of the left ventricle appear thick. Now, of course, if you've never done echocardiogram before this, so you will notice that you might not notice this thickness, but it is quite thickened wall there. Okay, and then if you go behind the heart, behind the descending aorta, there is echolucent space, which to a person who, you could confuse it to pericardial effusion, but this is a pleural effusion because this is behind the descending aorta. So this is actually a left-sided pleural effusion because heart is on left, so this is left pleural effusion. So that X-ray, if you remember, we more or less noticed a right-sided effusion, but the gentleman also had a left-sided effusion as well, okay, because there was quite haziness there. So again, more or less consistent with heart failure, having bilateral effusions. So now we go on to the next image, which if Dr. Ali plays there, it's more or less the same image, we've just reduced the depth. So right ventricle, left atrium draining into left ventricle into the aorta, okay, and in between aortic valve there and mitral valve between the left atrium and left ventricle. And we look at the contraction, the base of the heart is not contracting that well as compared to the apex, which is to the left, okay? And if we go on to the next image, please. And this is more or less the same image, but we have done a perpendicular short axis view. So we've cut through it at the mitral valve level. So right in the middle, we have the mitral valve. And if Dr. Ali puts the cursor right in the middle there, now we expect the walls to come right into the center, coming in, going out, coming in, going out. We see that the walls are not coming in so with that oomph or with that energy, okay? So the contractility is reduced there. And if you look at the full myocardium, it has a speckled kind of appearance there, okay, like the dotty white spots. Thanks, Mansoor. Next slide, please. And this is the same short axis view at papillary muscle level. And here you will notice we are slightly coming in towards the cursor in the middle there. So apex seems to be contracting slightly better than the base. And next slide, please. This is the apical four-chamber view. So Dr. Ali will point the right atrium there, followed by right ventricle there, where the cavities are quite small, and then left atrium, followed by left ventricle down there. Okay, we notice the atria more or less look similar to maybe bigger size than the ventricles because they are dilated, okay. It's typically sometimes called as owl's eye appearance as well for this particular condition. But more or less, these are suggestive of diastolic dysfunction, as well as if you look at the contractility, the apex, which is right at the tip there, seems to be contracting better than the bases, which are near the valves, atrioventricular valves. So the walls are not coming in that much as compared. Sorry, the playing of the images is not as a continuous loop, but you will make out the walls are coming in, I'm sure. And plus the walls look quite thick, as we mentioned earlier. If we go on to the next slide, please. And this is a subcostal image where we are going through the liver. So liver right at the top of the image, and then right ventricle over there, sorry, the right atrium there, and right ventricle where Mansoor is pointing now. And this is where we would measure the wall thickness adjacent to the liver there. And you also notice the interatrial septum is thickened, which is between the atria. Yeah, wonderful. And again, the walls seem quite thickened. Next slide, please. So we've more or less gone through our patient's echocardiography there, and ESC has given us all possibilities of causes of heart failure, a full list. So our patient should ideally be fitting into one of these categories there. If you have by now come up with a diagnosis for this patient based on that echocardiography, please feel free to put it in the chat box. Dr. Ali will let us know, or Naseem. So yeah, when you're going through the etiology, commonest we know coronary artery disease, hypertensive heart disease can also cause a similar picture kind of heart failure, okay? And again, you have the raised BNPs in these patients, and you have evidence of diastolic dysfunction or valvular disease, if there is any valvular. I did not show you any color flow Doppler images, but the patient didn't have any significant valvular heart disease or arrhythmias as the cause. We know our patient had atrial fibrillation, so we could say actually this is heart failure secondary to AF, but actually there's something more to it than AF. AF does contribute to heart failure, definitely, or any ventricular arrhythmias. Sorry, the previous last group was the cardiomyopathies, which is a big chunk, dilated, hypertrophic, restrictive, arrhythmogenic right ventricular cardiomyopathy, peripartum Takatsubas. Again, you usually diagnose these based on echo findings, and echoes might not be fully diagnostic. We ask for further testing with cardiac magnetic resonance imaging, CMRs, or a few further scans. If we go to the next slide, please. Then we have the congenital heart disease conditions causing heart failure. Then we have infective causes. We've come across COVID-induced myocarditis, but patients presenting with heart failure a few months down the line, to other infective causes, to drug-induced. We commonly do patients who are on chemo for breast cancer, etc. Irregular monitoring of their ejection fraction, because it can affect the cardiac contractility. And infiltrative diseases, amyloids, sarcoidosis, neoplastic conditions. These could also overlap with a few of your cardiomyopathies, because you can have a restrictive cardiomyopathy to hypertrophic cardiomyopathies with a few storage disorders as well. Next slide, please. And then you have conditions, again, storage disorders, Fabry's disease, and glycogen storage, endomyocardial fibrosis, post-radiotherapy, carcinoids, pericardial diseases again, and you also have other systemic conditions causing heart failure, nutritional, endocrine diseases, thyroid problems, or even autoimmune diseases, to neuromuscular conditions, muscular dystrophy, Friedreich's ataxia, which go along with cardiac involvement. So that's kind of a very thorough, detailed kind of etiology list for heart failure. I'm not sure if anyone's come up with a diagnosis for our patient so far.
You want me to double check?
Yeah, if any on chat,
nothing on the chat.
that'd be great.
And any diagnosis, guys? Anything that you would like to actually
What is the etiology for this heart failure?
mention that in the chat box?
Okay. Okay, that's fine. What we'll do is we'll move forward. So I think I have a slide where I have measured the wall thickness. This patient's wall thickness is 19 millimeters, which is normal is less than 12 millimeters. Okay,
there is someone in the chat saying infiltration.
okay.
Imran Aziz. Dr.
Yeah.
Imran Aziz saying infiltration.
Yeah, thank you, Imran. Yeah. And that's a very good differential. And infiltration, which could include the diagnosis, which I will come to soon. Okay, so next slide, please. So this gentleman had what's known as cardiac amyloidosis. Okay, now, it is quite an underdiagnosed condition. Now, as far as I used to think amyloidosis was rare, it's actually not as rare as we thought. 10 to 15% of patients who are more than 60 years old and have heart failure have this as their etiology. Okay, so that's a big chunk of over 60s heart failure. 10 to 15% is due to amyloidosis, cardiac amyloidosis. In fact, in a registry of post-mortem cardiac biopsies, over 80-year-old men, around 25% of their hearts had amyloid deposits in the heart. Okay, so that's quite a big population we're talking about. With the National Amyloidosis Centre in UK, in London, the diagnosis rate for cardiac amyloid has increased, from 0.2% in 1980 to around 6 to 8% in 2002, so which is continually increasing still. Okay, so you can see how with more diagnostic and more being aware of these conditions that we are increasingly diagnosing. And yeah, you have localized versus systemic. Cardiac amyloidosis is systemic amyloidosis. And then, I think there were, causes around 2,000 deaths. And recent advances in diagnosis treatment have made this condition actually quite treatable and much better a prognosis. Next slide, please, Mansur. So 95% of amyloid which infiltrates the heart is either AL or transthyretin, ATTR amyloid. Okay, so AL, as we remember, it's through the multiple myeloma plasma cell dyscrasia producing light chain related amyloid. And TTR can be the hereditary one, which is the V variant, that is autosomal dominant, okay, and or you can have the wild type, which is the acquired one, and this is the one which we are coming across more often nowadays. Next slide, please. And wild type has, as I've said now, it's increasingly in the elderly population, more or less carpal tunnel syndrome, biceps tendon ruptures. Those are the typical kind of other features they come up with. We've spoken about how often it's been found in the elderly folk. And that graph more or less shows the percentage in diagnosis rising. Next slide, please. And unfortunately, there's a huge diagnostic delay. More than 40% of patients are waiting for more than 4 years to get it diagnosed. The slide on the graph on the right side shows the blue charts, blue bars say more than 3 attendances till they were at least more than 3 attendances before they were diagnosed. And around median 17 hospital attendances prior to diagnosis for these patients. Next slide, please. This slide shows the prognosis based on the type of ATTR amyloidosis in the patient. So if you see the orange graph, which is the hereditary, so that has the poorest kind of prognosis as compared to the wild type and the non-V variant of the hereditary ATTR. The survival is slightly better. And next slide, please. So this is more or less an overview of cardiac amyloidosis, where we have patient's clinical picture, how they present. Not only heart failure is one of the diagnostic presentation, the other presentations are cardiac arrhythmias as well. So ECGs can pick up AV blocks to arrhythmias to, of course, low QRS voltages, etc. But not necessarily you find low QRS voltages with this much of hypertrophy in the patients. And imaging, I will talk through more detailed imaging later on, so I'll leave that. And then serum biomarkers, troponins are elevated, BNPs are elevated in majority of these patients. The diagnostic tests are biopsies in these patients. Next slide, please.
Sorry, Sunil, there's a question. Do we have to actually do serum-free light chains or myeloma screening?
Yeah. That's correct.
Mansoor, there is another question that presence of amyloid doesn't necessarily mean that it caused death or heart failure. Presence in the tissue. I think that's what
Yeah, no. That's very good question. Shall I answer the questions as we come along? Because some of them will be covered.
Yeah, definitely.
Yeah, of course. Okay. Thank you.
So next slide, please. So ESC, again, has produced what is more or less red flags when we should start considering cardiac amyloidosis as a diagnosis, because we can't think of this diagnosis in every patient. But if you've got LV wall thickness of more than 12 millimeters, plus any one of the following features, you should start thinking of screening for cardiac amyloidosis, okay, which is more or less heart failure in anybody over 65, aortic stenosis, and more than, you can have aortic stenosis and itself causing left ventricular hypertrophy, okay, so that comprises a big population on its own. But yeah, these are the features where you need to start thinking of, could this be cardiac amyloid? Or as we said, any other nerve involvement, biceps tendon involvement, proteinuria, bilateral carpal tunnel, and a few other conduction problems to family history problems as well. Next slide, please. One of the group of cardiologists had produced more or less kind of a clinical echocardiography score, and based on points 8 and above, you need to consider screening these patients for cardiac amyloidosis again. So quite detailed papers and research around these subjects, which can be accessed. But the main I would go with is the ESC criteria. Next slide, please. So now this is our patient where we've measured the wall thickness. I'm not sure if it projects well, but if you look at the bottom, on the top left corner, not of the picture, the numericals, yeah. So second from the bottom, LV posterior wall thickness, yeah, LVPWD is 1.94 centimeters. So 1.2 is our upper limit. So we're doing 19.4 millimeters, and you can't see the septum, but the septum is also 1.9. So more or less we are quite thickened over here with the cavity decreased size. Okay, so we've already met quite a few criteria of that ESC cardiac amyloidosis screening test. Okay, we have an elderly patient with heart failure with LV wall thickness more than 12 millimeters. Next slide, please. This is a strain pattern, which, if you remember, I mentioned the apex of the heart was contracting much better than the base. So it gives what's known as a bullseye appearance on our strain kind of imaging, where we do the global longitudinal strain mapping. And the last picture on the bottom, which is a bullseye appearance, basically apex is doing best contractility as compared to the base of the heart. Again, this is also another feature associated with cardiac amyloidosis. Next slide, please. So how do we go about diagnosing cardiac amyloidosis? So there's the invasive method to non-invasive method, okay? Now, of course, if you have cardiac biopsy positive, that's the gold standard, but we're not going down to do cardiac biopsy for every patient. So we have many other tests which can indirectly say this is cardiac amyloidosis. Or you have an extra cardiac biopsy positive with echocardiographic criteria. And by extra cardiac, we mean like nerve biopsies, like if you have carpal tunnel, you have median nerve biopsy, sural nerve biopsy, or biceps tendon biopsies, etc., which have shown amyloid deposit with echocardiographic features of thick wall with that speckled appearance. Okay. Or you have the non-invasive method, which is we do what's known as diphosphonate scintigraphy test, where you have grade 2 or 3 plus negative for serum. So your question about should we do myeloma screen? Yes, we should do myeloma screen in every patient if you suspect amyloidosis. You have to be negative for serum-free light chains, negative for urine immunofixation to diagnose the ATTR type of amyloidosis, plus echocardiographic and CMR criteria. Next slide, please. This is more or less the bisphosphonate scintigraphy scanning. So grade 0, you see the heart doesn't uptake at all. Grade 1, the heart very subtly uptakes if you can just make out there is slight haziness around the heart. Grade 2 and 3 are considered positive, where you can see heart has taken the uptake. And these techniques have been further kind of superseded with including CT SPECT scannings, which are more sensitive and specific in diagnosing these patients with cardiac amyloid. So grade 2 and 3 positive is considered one of the criteria to diagnose. Next slide, please. And this is more or less the diagnostic algorithm, where you have signs and symptoms, ECG, echo features, echo or CMR suggestive of cardiac amyloid. And then you have to do the hematological testing in these patients, serum-free light chains, urine immunofixations, okay? So if, and you're doing your bisphosphonate scintigraphy testing with SPECT if possible, because SPECT is making it more specific, okay? So scintigraphy grade 0, or then you've more or less ruled out any type of amyloidosis, AL or ATTR. Grade 1 to 3, so here this is where grade 2 and 3, if the hematological tests are negative, then yes, you would call this cardiac ATTR. You can do further genetic testing to differentiate the wild type from the hereditary V type, okay? And grade 1, unlikely this is amyloid, but you can go in for further biopsies, okay? Scintigraphy grade 0 with hematological test positive, you have possibly AL amyloidosis, and then you are doing further CMR tests, because you can still have light chains, which not necessarily are in the heart if the scintigraphy is 0, okay? So, but that's all hematological then, okay? And scintigraphy grade 1 to 3 with hematological test positive, then this is more or less histological confirmation, usually cardiac subtype of the AL amyloidosis. Is that all right? Shall we move to the next slide? So that was more or less our diagnosis of cardiac amyloidosis. Then we go about treatment. Now, treatment is more or less the treatment for the condition. So if I diagnose aortic stenosis due to cardiac amyloid, your management is more or less the same. In fact, you go with be it valve replacement or TAVIs for these patients, and the prognosis is similar to non-amyloid atrial stenosis. Heart failure, again, more or less similar. Heart failure management, fluids, controlling fluid, diuretics, beta blockers, ACE inhibitors, ARBs, with further kind of our 4-pillar management for heart failure with all the newer drugs coming up. To considering a few other procedures for these patients. Thromboembolism or AF, again, these patients, you want to anticoagulate them because they are at high risk of thromboembolic diseases. Conduction disorders, as you would consider pacemakers based on what, if they are having heart blocks, and ICDs for secondary prevention. For primary prevention, it's not recommended, so unless they've had a ventricular arrhythmia. Next slide, please. So that was more or less treatment based on what they have presented, and you're treating that condition. But you also have specific therapies for cardiac amyloidosis, especially the transthyretin amyloidosis has several drugs which are right from amyloid stabilizing kind of drugs to reducing the production of the amyloid protein in these patients. And these have had more or less game-changing results in these patients, and their prognosis has improved quite considerably. So yeah, the specific treatments have changed the course of cardiac amyloidosis in these patients. And if it is AL type, which is associated with multiple myeloma, MGUS, mainly plasma cell dyscrasias, there you have specific therapies towards the myeloma mainly, which would control the amyloid protein. You can still use amyloid stabilizing drugs, which have been used in these patients, the transthyretin amyloidosis as well. Next slide, please. So more or less in summary from ESC, this slide says suspect, screen if left ventricular wall thickness is this much and you have more or less more than one or red flag feature, which we mentioned through. Then you diagnose these patients based on the diagnostic criteria we mentioned, the diagnostic algorithm we go through. And then you treat, so treat the complications which they have caused, heart failure, AF, thromboembolism, etc., to disease-modifying therapy for the specific type of amyloid, ATTR, AL. AA, we haven't talked that much. It's more or less secondary amyloidosis to secondary to any of the chronic infections, etc. Again, you're treating the underlying condition over here mainly. But as we mentioned, the majority of cardiac amyloidosis is AL and ATTR type of amyloid. Next slide, please. So in conclusions, identify the etiology for heart failure. So heart failure diagnosis is not complete without giving an underlying etiology. Cardiac amyloid is a serious progressive infiltrating disorder, and often there are delays in the diagnosis. It can be hereditary or acquired. Look out for any red flags that raise the suspicion of this diagnosis. And early diagnosis is essential for patients to gain the most benefit from the treatment for this condition. I think that's me. I hope that's all right.
No, thank you. Thank you very much, Sunita. I think this was an amazing talk on cardiac amyloidosis. You took us through right from the very beginning of the presentation to kind of actually essential investigations, much so kind of actually needed investigations. They talked about the management and also the classification. I think this was a very sort of insightful talk on cardiac amyloidosis. Now, coming from a nephrologist, I see a lot of patients actually with amyloidosis ending up with renal sort of failure and ending up actually on dialysis. But this was a very different perspective. But thank you very much for kind of actually going through that talk. So do you mind if we actually do the second talk and then we can actually have the questions? So for
Sure.
Get the questions, unless until you want to kind of actually answer some of the questions now.
I don't mind either way, Mansur. Yeah.
Okay. So maybe we can talk, take one or two questions, and then I can start my talk.
Sure. Yeah.
Interesting. Any correlation between amyloid elsewhere cerebral and incidence of cardiac amyloidosis?
So a good question. Now, cerebral amyloid is quite an interesting topic, as we know. It's actually not related to, as you know, with dementia and everything, there's amyloid fibrils being identified in the brain, but it's actually not related to systemic amyloidosis. And when systemic amyloidosis has been looked at, it's mainly kidneys, cardiac. Those are the main kind of organs which have been involved. And kidneys typically is with the myeloma, the plasma cell AL type of amyloid. And cardiac typically it can be both, as we mentioned, but ATTR doesn't affect that much to the kidneys. I hope that answered the question.
Yeah. Okay. Another question, actually, we talked about the sort of, the AL amyloidosis. How about the AA amyloidosis, secondary connective tissue diseases? Would that actually also can affect the heart?
Yeah, no, thanks. As I mentioned, so 95% are ATTR and AL. So yes, the rest 5% are left with, there are around 120 types of amyloid proteins apparently, okay? So the rest 5% can be comprised of all these bits, okay? So AA is included, as we saw on ESC's final conclusion slide as well, okay? But we don't find it that often. Of course, when it's typically AA, I'm sure, Mansur, it would be renal, which I would have thought proteinuria, which picks up the main diagnosis. But it's just having that open mind of considering amyloid as an underlying etiology for your patient there for heart failure with that increased LV wall thickness than a simple aortic stenosis with concentric LVH, which can happen with aortic stenosis as well.
Thank you very much. I think we can just pause here, give you a bit of a so you can have a drink or so. And it'll be good actually, Cynthia, if you can just moderate the chat for me, because I think Dr. McQueen has to leave at some point during my talk. So I can start. Thank you very much, Cynthia, once again. So the second talk is actually about fever in a dialysis patient. I'm sure a lot of you have actually come across dialysis patients. You, wherever you work, if you're working on acute floor, if you're working actually in A&E, or if you're working on general medical wards, or even surgeons, you do come across patients who are on dialysis. The structure of actually the dialysis care and nephrology care is sometimes dialysis patients do not necessarily end up on the renal ward because of the pressure on the tertiary center on the renal beds. So you may actually end up having to look after the dialysis patient for a day or two before transferring them to a renal unit or the renal tertiary center. So I just wanted to actually give you or talk you through about this particular case that I have come across, I've looked after, and then just to give you actually a bit of an insight about patients who present, dialysis patients actually present with fever, and then literally just to kind of actually make you think that they're slightly outside the box when you come across dialysis patients. And this is, again, I'll be talking a lot from my experience of actually doing nephrology for the last sort of 15 years or so. Okay, so talking about this case 78 years of age female who actually had end-stage kidney disease and has been on hemodialysis since January 2014. She actually had acute kidney injury in January 2014, well, acute on-continuous impairment, and she actually ended up on dialysis and became dialysis dependent. Her past medical issue was type 2 diabetes and diabetic nephropathy. Just to kind of remind the audience that diabetes is still the #1 cause of patients ending up on dialysis. I was reading a literature from 2005, an American literature, US renal database, where diabetes actually was the #1 cause for patients ending up on dialysis, and 2021, we still actually have diabetes as #1 cause, going hand in hand with hypertension. She had an echo in 2018, and that was relevant because I'll be showing you some recent actually echo images for this patient, showing possible mild LVSD. And basically she was on, in terms of dialysis, she actually had a tunnel dialysis line. You'll just say, well, the patient's been on dialysis since 2014. Why is she having a tunnel line and not actually a fistula or not a transplant? Well, the transplant actually was not discussed with her because I think I wouldn't be ageist here, just because of lots of other issues with the patient and not actually engaging with the transplant services. But in terms of access, it was a patient's choice not to actually have a fistula, and she preferred to have the line. This is quite a long period for someone to actually have a tunnel line in 2014 to 2021. And according to the X-ray, the notes, the line was actually placed in 2015 because she had temporary lines in, and then the line was sort of the second permanent line was actually placed in 2015. Okay. So the patient presents. I was doing my week of on call. So yeah, almost about 400 dialysis patients. So not necessarily I know each and every patient in the unit, but some patients are actually quite quiet, and they don't usually bother you, and they only come into you only come across them when they become unwell. They are actually admitted to the renal ward. So the patient actually was my first interaction with her. She was quite unwell. She was under the care of another consultant colleague, short of breath, and was having some productive cough. She was treated for chest infection in the community with 2 lots of antibiotics 2 weeks apart. So you could see that the patient actually had some contact with the GP in the community and had 2 episodes of chest infection with 2 different antibiotics. I'll show you the chest x-ray in the next slide. So I'm sure you could actually appreciate from this chest x-ray, it looks like a bit wet. You know, it's an AP erect mobile x-ray, difficult to kind of actually see the left base, and you could see that there's actually a line hanging out on the right side of the chest. This is a tunneled access line, which is usually placed by us as nephrologists or nephrology trainees. If a patient's got a complex vascular history, then usually we do ask our individual radiologist to help us with that. But usually, kind of actually, it is the nephrologist who put the line in. So if you don't find me answering the phone, I'm maybe probably putting a line somewhere on our renal unit. So going back to the main sort of case, the patient's CRP was high, 179, and then just going to actually move to sort of 230 literally during the course of her admission. She was actually given oral antibiotics and clarithromycin for pneumonia, and blood and line cultures were taken as well. She wasn't actually ready for home. She was under the care of the elderly. So this initial admission was actually under the care of the elderly. And then she was sent to a rehab ward where she could be easily dialyzed at one of the satellite units and was looked after actually by the elderly team. DNA CPR was also discussed. So at this point, there was no nephrology interaction. There was literally just interaction with the care of the elderly. They had maybe spoken to a nephrology registrar and then send the patient to a rehab ward close to the dialysis unit. So positive cultures were actually shown. So the microbiology was the weekend consultant calls where I actually got to know that the blood cultures was literally positive. She had a Staph aureus in both cultures, in both bottles, and that was from peripheral. The question to the audience is, what would you do now with antibiotics? She's actually on clarithromycin and amoxicillin. Don't forget, she's also had some episodes of infection in the community. She had a couple of oral antibiotics. Looking on the GP records, it was actually amoxicillin and augmentin, and I think she was started on amoxicillin and clarithromycin this time. What investigations are needed next, and where do you think the focus of infection is? So it'll be helpful to kind of actually for someone to write something in the chat box to know what you're thinking at this stage, because obviously you may be the care of the elderly as you was actually looking after this patient, and you haven't got a renal sort of actually consultant registrar actually 24/7 on that unit, and you need to kind of actually do something about this patient if you get this positive culture. So if Naseem or Dr. Tikchandani could monitor the chat for me, that'd be great. So what next? You would do something about this. I'm sure you probably want to kind of actually review the patient. You want to maybe send more cultures. You want to kind of actually look for the focus of infection, because don't forget, this is Staph aureus MSSA infection. So line cultures were sent, and then the line cultures, in fact, the cultures were actually labeled wrongly because no line cultures were sent on the first sort of presentation. And then line culture, when I was spoken to, I asked them to kind of actually send the line cultures, which did actually come back as positive. This really worries me, because if you've got a Staph aureus infection, you worry about where is the focus? Is it in the heart? Is it the back? Elderly lady, she was actually complaining of some sort of pain in her lower back. And is this, because obviously you need to worry about the seeding of Staph aureus and soft tissues, joints, skin, and literally kind of actually in the heart. So where we go next from here, does anyone think that there's anything to do with the line with the focus of infection here? Because don't forget, she's had the line since 2015, and the line cultures actually also come back as positive. So I'm showing you the echo here. Could anyone just actually give me a spot diagnosis here on the echo? I've made it easier by putting an arrow there. Anyone? Anyone in the chat?
So I don't see, oh, they've said tricuspid vegetation. And
Excellent.
your last question, they've said send anything that you can get for culture, including from the line.
Excellent. So yes, Dr. Aziz, this is actually tricuspid vegetations. In fact, let me just kind of actually show you that. So that is the right, Sunita, you may have to correct me if you've got the specialist interest in echo. So this is the right atrium leading into the right ventricle. This is a tricuspid valve where you've actually got this mobile thrombus actually sat there. And this is, and I can't really show you the line clearly, but I can tell you actually the line was not removed at that stage when we've had the echo. When the audience may ask me, when do you actually remove the line, or when does renal decide about removing the line? So it's a very sort of tricky question, but equally easy to kind of actually answer. Let me go through the echo sort of report. This was the actual echo report for this patient. So echogenic mask, this is the vegetation seen on the tricuspid valve. Quite a big one, actually, I would probably say, not being a cardiologist or an echo sonographer, but it is actually quite an important finding there. The patient actually had good systolic function. So the diagnosis at that point was literally the infective endocarditis, risk factor was the dialysis line. Now, the dialysis line actually had to be removed because you remove the dialysis line when you've got actually bacteremia, especially if it's a Staph aureus bacteremia. If you've got someone who's got persistent sort of bacteremia, clinically not improving, and also if you've actually got someone who is really unwell and septic, so you need to kind of actually remove the line to facilitate sort of the recovery and ensure that the patient's actually clinical progress is not affected because of the line is there. Now, sometimes it's very difficult because don't forget that the dialysis patients, actually this patient was lucky because she's only had one line, in fact, two lines, one temporary line and then the permanent access. Some patients actually do not have good vasculature. They may have actually had multiple lines, and it's very difficult to remove the line because you know that you won't be able to put another line in. So you've got to really take that into account, and sometimes actually you've got to take into patients' preference as well. There's some patients which say, no way I would actually get the line removed, no way would I would have another line put in. But again, you've got to explain to them the risk of actually having the line, because not removing the line won't be able to kind of actually cure the condition, and the Staph aureus bacteremia untreated literally leads to disastrous, catastrophic sequel. And I've actually come across a lot of patients who had issues where the lines were not removed, or the clinicians may have actually had a very sort of high threshold of not removing the line. Obviously, you look into other examination, you've got Staph aureus bacteremia, they've got swollen joints, have got any spine tendons, have got any skin lesions. We did actually do an MRI spine as well, which did not really kind of actually show anything at the back, but it did show sort of some lesion on the lung, which I'll come to in the next few slides. So obviously, you refer to cardiology. We also actually were discussing on a regular basis with microbiology. At this point, I've actually moved the patient from the elderly rehab ward to the renal ward, actually acute renal ward, to ensure that actually we manage that, because obviously we wouldn't have been able to do that on the elderly rehab ward. Micro did advise us to pretty much repeat cultures on a weekly basis, and the duration of the treatment will be 4 weeks. But again, micro advice was literally 4 to 6 weeks, depending on the clinical progress, and also the removal of the line, yes, which was removed, and also to kind of actually see whether the patient was actually improving on treatment, and the treatment was IV flucloxacillin.
Mansoor, we need to conclude the meeting, sorry, because I didn't realize that actually the other meeting is from my same Zoom account.
Okay, all right.
Really
Okay.
sorry. Yeah.
Okay, shall I just another few minutes? Yeah, that's all right. Yeah. Okay. So management tunnel line removed, but don't forget the patients actually need further dialysis access. If femoral line was inserted, we plan to kind of actually have blood cultures. Now, let me just quickly go through the common cause of death in dialysis population. So remember your cardiovascular disease, infection, hyperkalemias, missed dialysis, withdrawal from dialysis, all these are actually the causes of death in dialysis population. So fever in dialysis population, if any take-home slide, this is actually a take-home slide that you need to just go home with. And remember that the bronchopulmonary chest infection is really common. Don't forget, they're wet. If they have not actually had good fluid removal on dialysis, wet chest actually would lead to chest infections. Pyelonephric, even if they don't pass urine, stasis could actually be the cause. Access infections, the first three are the common cause for infections in dialysis patients. And obviously your diabetic complications, frailty, chronic disease burden, biliary abdominal causes, neoplastic. Don't forget recurrence of vasculitis in these patients, failed transplant. People forget that some of the dialysis patients actually had failed transplant. They may still have a transplant kidney left in them. So rejection, opportunistic infections like CMV, EBVs, BK virus, listeria, all these actually are common causes, aspergillosis, common causes of actually infections, opportunistic infection in these patients. Then examine the wound if they've got any wounds. Don't forget they may have actually previous catheters like peritoneal dialysis catheters or peritoneal dialysis exit site wounds. Unexplained where this is where an MDT approach is actually needed. And if you're living in an area where literally you've got actually a lot of ethnic minority patients, then remember to kind of actually look for TB and go and find whether they've got actually TB or not, because I've literally kind of actually had lots of patients who've had delayed diagnosis of TB in my dialysis population. So literally MDT approach is very important. Timing of cultures. So when you're doing cultures, do a line culture. So you may not actually be familiar with line culture, but ask the dialysis unit, ask the dialysis staff, ask the nursing staff who look after these patients actually on the dialysis unit. Would you do dialysis line culture? It's very simple, it's very easy, and the nurse can do that actually without any problem, and ask them to label that properly. In random move, suspicion of line infection, especially actually fungal infection, MSSA infection. Review the cannulas, the catheters, timing, doses are really important. So flucloxacin dose, the vancomycin dose, all these are really important in your dialysis patients. Speak to nephrology, speak to pharmacy. We're always kind of actually helpful and always be able there to kind of actually advise you. So we would never mind if you actually ask us about one of our patients. And obviously if they've got MSA suppression treatment. So I'll just skip this slide, but every case of prolonged fever is an enigma which remains a challenge to all scientific and communicative skills of a good physician. I still actually have had patients in the past where I could not really figure out where the infection was coming from. It really kind of actually disturbs me whether when you've examined and investigated, you could find the cause for their fever. So thank you very much.
Mansoor, thank you very much for this excellent talk. As I said, the other meeting was arranged also via the same Zoom account, so it's not letting us start the other one. So I think if we can conclude the session. And
that's fine. Thank you very much. So you've got actually, if there's any questions, please do ask me or Dr. Dikchandani later on, or you can email us. I'm sure we'll be able to actually answer those questions. But thank you very much. It was a lovely session. Thank you, Dr. Dikchandani, for actually taking us through cardiac amyloidosis. And I hope actually you got some messaging about, how do you investigate and look after patients on dialysis who present with fever. Thank you.
Thank you very much. Thanks, Mansoor. Thank you, everyone. Thank you. Bye-bye.